Okay, I'm going to, this is Task 6, I'm going to monitor using an anesthetic chart. We actually have a patient that just had a dental, and I've got the surgery records right here from the dental. So I'll go over how the physiologic status and the reflexes affect how we monitor. So first of all, you want to always be monitoring the heart rate. The heart rate, you can physically monitor through the apical pulse through the thoracic wall. Usually if it's like a smaller cat, or if it's a cat, I can grab right underneath and hold with my thumb and my forefinger and monitor that way. We also have the ECG always hooked up, and then you can also use a stethoscope to manually to monitor that. Mechanically, I don't always trust our machines. We have one that likes to double read the heart rate, so I always manually check it with the pulse rate and then the stethoscope as well. You also have to realize that when a patient has been anesthetized, it depresses the heart rate and the respiratory rate, so you want to be aware of that. The heart rhythm, you're looking for abnormal rhythms. This is another reason why we do the pre-anesthetic exam, or the doctor does the pre-anesthetic exam, so we can detect a murmur and we can adjust accordingly with medication. You might need a different medication to knock down the PET. Mucous membrane temperature. We monitor the temperature prior to anesthesia, during anesthesia, and then again at the end of anesthesia. A lot of times the patient will be a little bit colder, and we'll have to either leave them on the bear hug or with the bear hugger, or put heated water bottles around the patient to keep the patient warm. And then we also have heated discs that we can put underneath a couple of towels or blankets to keep the patient warm. Capillary refill time. Capillary refill time, again, I'm reading off of my anesthetic sheet. Capillary refill time is when you press on the gum and you want it to be less than 2. And that indicates, less than 2 indicates good tissue perfusion. If it's greater than 2, that means that the tissues are not perfusing correctly. Mucous membrane color, you want it to be a nice light bubblegum pink color. Darker red mucous membrane color can indicate some sort of severe blood infection or sepsis. Bluish is cyanosis. You need to check your ET endotracheal tube, check your tie, make sure your oxygen source actually has oxygen in it. If they're blue, that's not good. Pale means also poor tissue perfusion, and it can indicate anemia. Pulse and blood pressure, we have a Doppler machine that we can do. You always need to use the Doppler for arterial blood, and you can hook that up. There's a couple of different places we've used under the tail. You can shave a little space behind either any of the feet in the carpus area, and then what you want to do is shave it, use alcohol, and then put the ultrasound gel, and then you hold the Doppler there until you get the heart rate, and then you want to have the cuff on the leg, and then you want to squeeze it up until the point where you start to hear the pulse rate again. And we do the average of 3 on the blood pressure. We also have on our machine, if the patient is in surgery, we have a cuff that we attach to the patient to do ongoing monitoring. We can do that manually, or we can set it to automatically recheck it every minute or so. Respiratory rate. Respiratory rate is a really good indicator of how deep the patient is. What you want for an anesthetic for dogs and cats, respiratory rate is between 8 and 20. And so if it goes below that, you want to let the doctor know, and above that, you want to let the doctor know. That is a good surgical plane for the patient to be at. The monitoring equipment we use for respiration, a capnograph monitors expired CO2, also stethoscope, and you can watch the rebreathing bag. You can also watch the patient's chest go up and down. Sometimes if you're in surgery and there's drapes and a lot of blankets and things over the patient where it's difficult to see. Like watching the rebreathing bag is a really good indication of respiratory rate. Reflexes. So there are several reflexes that indicate the plane of anesthesia. I have my little deer prop here so that I can kind of show you. So the ear fleck reflex, if you would flick an ear, the patient, the pinna, the patient would retract the ear and they respond to that. So if I was to flick that, the patient would kind of do a jerk. The pedal withdrawal reflex is when you, that one has a squeaker in it, so I won't do that one. You have to use a little bit of pressure, but if you press on that, then they should withdraw their leg, and that is called the pedal withdrawal reflex. So when pressure is applied, and these reflexes start to diminish as they go into greater state of anesthesia. The palpebral reflex, right in the corner of the eye. If you sorry, I can't see. If you press right into the corner of the eye, you'll get a blink. And as they go further into anesthesia, they will not have that reflex. And then as they come back out of anesthesia, they will gain that back again. The corneal reflex is when you tap on the cornea. Not a great indicator because they don't really lose that reflex all the way into the deep stages of anesthesia. So I think it's used primarily for the time of death. Laryngeal swallow reflex is the reflex when you're trying to intubate. A lot of times for a cat, for example, they'll have a laryngospasm. So you'll put down a little bit of lidocaine down there. It helps keep the epiglottis, helps you be able to pass the tube through over top of the epiglottis. So the swallow reflex is actually needs to be absent to intubate. And then that's also how we gauge when to extubate, because when they start to regain the swallow reflex, then we will pull the tube so they don't chew the tube. Jaw tone. Jaw tone is when you can put a bit of pressure on their jaw and actually open it without them fighting you too much. And this is when their jaw tone is slack enough, then you're able to move forward with the intubation. Eye position. The ideal eye position for surgical plane of anesthesia is medial lateral. So you want the eye to be rotated somewhat inward. If the eye is central, that's a light level, and it's also a very deep level. Things that affect the so if you, for example, use ketamine, it doesn't have any effect on the eye position. So if you did use ketamine, you can't really use the eye position to gauge the level of anesthesia. Anesthetic depth increases, the pupil constricts with the light shown on it. Good things to know: loss of consciousness borders between stage 1 and stage 2. Loss of spontaneous muscle borders is between stage 2 and 3, and then loss of all reflexes, widely dilated pupils, and flaccid muscle tone. Cardiopulmonary collapse is stage 4, and we never want to have that happen. So you need to be able to, for full evaluation, you must be able to assess multiple parameters, and you can't always just rely on your equipment. Although they're nice to have, you need to manually and be able to recognize signs of too deep of anesthesia and too deep of a plane, and be able to pull the patient back out to keep them at a safe level.